Okay, good evening, everyone. My name is Megan Glenn, and I am the ALF's National Senior Director of Programs. I'd like to be the first to welcome you to tonight's academic debates presented by the American Liver Foundation. We are excited about our topics, proud of our teams, and grateful to our sponsors, and honored to have such an outstanding panel of judges alongside our esteemed moderator. We're grateful that you would take the time out of your busy schedules to join us and hope you enjoyed the evening. Tonight's academic debate is being delivered on the Zoom webinar platform and will be recorded. During the presentations, if you have any questions, please hover your mouse over the bottom of the screen and click on Q&A. Then simply type your question into the Q&A box. For all other comments and to cheer on your favorite team, please use the Q&A box as well. Again, please note that this program is being recorded and will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we are extremely grateful for our ongoing sponsor support. We're so grateful to our premier supporter sponsors, AbbVie and ASI, for supporting the 2022 academic debates. Let's hear what our premier support sponsors have to say. We are so appreciative of our sponsors' support. Without their support, we would not be able to continue to fulfill our mission. Before I introduce our moderator, I want to acknowledge tonight's technology team, Barb Potter and Karen Irwin. We could not present tonight's event without their expertise. Now it's time to turn the program over to our moderator for tonight, Dr. Kimberly Brown, Chief of Division of Gastroenterology and Hepatology, as well as the Associate Medical Director of the Henry Ford Hospital Transplant Institute. Dr. Brown specializes in hepatology with an interest in liver transplant, liver disease, and cirrhosis. She's involved in clinical trials with medications used to treat liver diseases. These clinical trials may involve liver transplantation, medical therapies for liver disease, or management options for patients with cirrhosis. Tonight, Dr. Brown will be saying a few words about the history and format of the debates. We'll explain how you can help support the mission of the American Liver Foundation, how you can promote the debates through our social media, and introduce our esteemed panel of judges for tonight's debate. Dr. Brown?
Thanks, Megan. Thanks for the introduction. I just want to welcome everybody to the second night of the American Liver Foundation's Academic Debates Madness Week. This is exciting. The academic debates have been hosted by the American Liver Foundation for over 18 years. These debates have been recognized continuously for the educational excellence and have been a long-standing signature program of the American Liver Foundation and AASLD. And the debates are our most popular non-CME programs among healthcare professionals in various medical disciplines and fields. So this year, we're engaging in a week-long March Madness. So we've done these at our program before, and I'm sure many of you have as well. These are academic debates which started on March 28 and will conclude at the end of this week on April 1st. Each team will consist of 2 fellows and 1 mentor from nationally recognized institutions, and each individual debate will feature 3 judges and 1 moderator. The winning teams will be selected based on their research as well as the presentations of both their cases and rebuttals. So there was a medical advisory committee that set forth a specific subject matter and perspectives that each team needs to argue this year. The topic for this week's debates are alcohol-related liver disease, autoimmune liver disease, fatty liver disease, liver cancer, pediatric liver disease, and viral hepatitis. So as you know, if you've participated in these before, there are no wrong or right answers to the topics. The different research evidence and perspectives presented will often lead to invigorating discussions. We provided the criteria to the team members to focus on creating professional and well-researched PowerPoint presentations, practice and refine their rebuttal skills through thorough research of their assigned topic and position. And they need to be prepared to show how quickly they can think on their feet during the Q&A. Tonight, it is our pleasure to present 3 exciting debates featuring teams from the National Institutes of Health, Cleveland Clinic, Florida, Yale University, University of Maryland Medical Center, Boston's Children's Hospital, and Brown University. The topics assigned to the debate teams are chosen specifically because they're really not questions that we have settled in the medical literature, or in some cases are ethical in nature. And so there are really no right or wrong answers. And through these debates, we seek to stimulate higher thinking about significant issues that impact the lives of people with liver disease. The debates are fast-paced. We will start each debate with the pro presentation, followed by the opposing con presentation. Each side is allotted precisely 8 minutes. They will be cut off if they extend beyond the 8 minutes to present their arguments. And our diligent timekeeper is there to disconnect his or her audio and video should they exceed their time. But we will do our best to transition smoothly from one presenter to the next to keep the program flowing. After both arguments have been presented, each side will have the opportunity to challenge their opposition with a 5-minute rebuttal. Debate teams don't use slides during the rebuttal, and teams again will be closely timed. And this will be followed then by a 5-minute Q&A session led by the panel of judges following these rebuttals. We would like to acknowledge the demanding work of our presenting teams and their mentors, and really express our appreciation to the sponsors, our judges, our timekeepers, and the technology teams. And most importantly, we thank you for joining us this evening. The American Liver Foundation has been a trusted voice for liver patients for 46 years. Leadership and staff always strive to ensure that the foundation is a reliable source for patients, caregivers, and medical professionals. Educational programming has been presented consistently to ensure that people have access to information about a myriad of liver disease topics. All programs are recorded, as is this one, and uploaded to our YouTube channel for easy access to people who want to view the programs again, and are available for those who were not able to participate in real time. Printed literature has been created and updated as well. And our web pages about liver disease and transplant-related issues are constantly updated. All resources are available at no charge to the public, and the National Helpline remains a vital source of assistance for people who want and need information about medical diagnostics, various liver diseases, and links to financial aid, patient and caregiver support, and more. The ongoing advocacy of the American Liver Foundation makes certain that issues pertaining to access to care and treatment remain a priority for legislators who make important decisions about healthcare policy. Our walks, marathons, and patient and professional educational programs are key components that unify the liver community, and we cannot do any of our work without your generous support. ALF is a not-for-profit organization and as such relies on donations to carry out its mission. So please be as generous as possible tonight and help the ALF continue to provide resources to patients and caregivers, the healthcare community, and the general public. Tonight's fundraising goal is $5,000. Any and all support is greatly appreciated, nothing too small and certainly nothing too large. But before I introduce our topic and team members, it is my privilege to introduce our outstanding panel of judges. These judges will join us at the conclusion of each debate tonight to ask thought-provoking questions of our debate teams. So first we have Dr. Peter Gali. He is the professor of medicine at the University of Florida in Jacksonville. He is professor-in-chief of the Division of Gastroenterology. He is the program director of Gastroenterology Fellowship in the Department of Medicine. Specialties include gastroenterology, hepatology, and liver transplantation. Next, we have Dr. Amreen Dinani. She is an associate professor at Mount Sinai in New York. She has served as an associate program director to the Gastroenterology Fellowship Program at the New York Methodist Hospital in Brooklyn. Her clinical and research interests are in non-alcoholic fatty liver disease, and she is an investigator for many ongoing clinical trials in NAFLD. And then finally, we have Dr. Richard Sterling, professor of medicine at VCU. He is currently section chief of hepatology, medical director of viral hepatitis, associate program director for scholarship and research for the core internal medicine residency, and assistant chair for research in the Department of Medicine. Richard's clinical interests include HIV, viral hepatitis, and liver cancer. The key clinical question for the first debate of this evening is whether or not patients with decompensated hepatitis C cirrhosis who are not liver transplant recipients should be offered HCV treatment. As a reminder, the pro presentation will be 8 minutes, followed by the con presentation of 8 minutes. Next, we will welcome our rebutters separately, who will have 5 minutes each to refute the opposite team's presentation. This will then be followed by the judges' Q&A. So here's the first topic. Should patients with decompensated HCV cirrhosis and possibly liver cancer who are not liver transplant recipients be offered HCV treatment? Our pro side is the National Institutes of Health, and taking the con position is the Cleveland Clinic in Florida. So here are our debate teams on the next slide. Presenting the pro position that patients with decompensated hepatitis C cirrhosis and possible liver cancer who are not liver transplant recipients should be offered HCV treatment. So this is the National Institutes of Health. Mentoring this team is Dr. Theo Heller, and the fellows representing the National Institutes of Health are Dr. David Yardeni and Dr. Gracia Viana Rodriguez. The Cleveland Clinic Florida will then argue the con position that patients with decompensated hepatitis C cirrhosis who are not liver transplant recipients should not be offered hepatitis C treatment. Mentoring this team is Dr. Antonio Pinna, and the fellows representing the Cleveland Clinic Florida are Dr. Mohammad Alomari and Dr. Mamoon Rashid. So Dr. Gracia Viana Rodriguez from the National Institutes of Health will now present her position. And once she has her slides up, then the timekeeping can begin.
Good evening. First, I want to thank the American Liver Foundation for allowing us to participate and represent our institution and all the people who is attending this debate. My name is Gracia. Today, my team, Dr. Yardeni, and our mentor, Dr. Heller from the National Institutes of Health will be discussing if we should be treating patients with decompensated HCV cirrhosis who are not liver transplant recipients. The answer is yes. Let's start by setting the stage. Who is truly our patient? There's confusion in the literature of what decompensation means. Older literature includes only child B and C patients, but modern definition also includes any child A patient who developed portal hypertension complication. So we're actually talking of a wide spectrum of disease with very different quality and life expectancy from each other. And here I bring you an example. Johnny, a 59-year-old happily married male with 3 kids and sole provider for his family that enjoys his job as a doorman, where he proudly has only missed 5 days of work in 20 years. Past medical history, significant for HCV, treatment naive. Decompensated cirrhotic with ascites, control on diuretics. Low-grade CLL, diagnosed 3 years ago, not on treatment. Male, 16, not a transplant candidate, unfortunately, in the setting of underlying malignancy. Maybe you're thinking this is a unique case, but what will happen if Johnny was your patient that was not able to be listed due to lack of insurance, poor social support, mental illness, or struggling to show addiction rehabilitation? Would you advocate to treat him? The answer is yes, and the guidelines support treatment. ESO clearly states that HCV decompensated patients should be treated with direct antiviral therapy, DAA, as well as ASLD, who mentions that treatment is recommended for all adults, except those with short life expectancy. But let's look a little closer to the data that support this recommendation and consider if this applies to our patient. So why should we treat? High success rate, well tolerated, short-term benefit, long-term benefit, cost-effective. Let's take a closer look to each one of them. As we can see, since DAA era treating patients with decompensated cirrhosis is over 80%, comparable to their compensated counterparts, as all these studies have shown us. Well tolerated. DAA persistently have shown us to be well tolerated, even in our most fragile patients with decompensated cirrhosis. These 3 studies show treatment discontinuation rates as low as 1% in this group. Study after study continue to show MELD score improvement up to 9 points after DAA treatment in the compensated cirrhotics patient. This study from Foster et al. From 2016 is a pretty good example of the short-term benefit of treating this patient. In this study, they compare 467 decompensated cirrhotics after treatment versus a similar historical cohort of untreated patients. In our first figure, you can see the comparison of MELD score at SBR24. In the y-axis, you have the MELD score change over time. Most of the untreated patients had an increase in MELD score from baseline over time compared to the treatment group that had a clear improvement. But does the improvement in MELD score, does really translate into improvement of clinical related events? Well, the study once again shows that patients will present with lower number of decompensations and death compared to the untreated uncontrolled group. Looking at this, in which group would you like Johnny to be after 6 months? I would like him to be on the treated group. What does the evidence tell us about long-term benefits? First, we have the study by Payut et al., where they evaluate 483 decompensated cirrhotics after 3.5 years. They found that in the group with MELD score more than 20, there was significant change in HCC, all-cause and liver-related mortality, and a trend with liver transplant. Then, a recently published study of Joe Nochi, where they used the Chronic Liver Disease Questionnaire, CLDQ-HCV, to evaluate health-related quality of life, show the initial benefit of SBR persisted up to 5.5 years. As we can see in this figure, the compensated cirrhotics represented by the dark gray line, never reaching over to the back to baseline, represented by the red line. We have talked about liver-related benefits, but there's also evidence of preventing and treating extrahepatic disease that can come with HCV, like decreased cardiovascular risk that can decrease up to 2 to 3 folds compared to controls, according to the paper published by Adinolfi in 2020, as well as oncological and metabolic complications. Let's talk about the elephant in the room. What about cost benefit? In 2014, over $4 billion were spent on the treatment of decompensated patients in the hospital. If we extrapolate that HCV decompensated admissions are roughly 45 per 100,000 per year, as we know, the cost of admission for decompensation is over $8,000. Then we can calculate the US is spending $1.23 billion a year on hepatic decompensations due to HCV alone. Treating patients that are still struggling with IV addiction and needle sharing can save more money by preventing future infections that will lead to further decompensations too. Lastly, as we know, data suggests that curing HCV might have a improvement in occurrence of HCC. With high cost of HCC treatment, we're saving probably $30,907 per patient who does not develop HCC. We're in a new era where hepatologists that practiced 20 years ago will love to be part of, because now we have an effective treatment for patients with hepatitis C. We all agree that we are looking to give Johnny the best chance. But today, we're not talking about a regular hepatitis C patient that has options for treatment. We're talking about the compensated HCV patients do not have any other option, since as today, they're not liver transplant candidates. But as we have shown you with HCV treatment, you might be offering that extra time with quality of life they might be looking for. We all agree this is far from perfect option, but this might be a true gift for Johnny and his family. Thank you.
I can learn to.
Thank you very much, Dr. Rodriguez. Now next, presenting the con position from Cleveland Clinic, Florida is Dr. Mamoon Rashid.
Are you guys able to hear me?
Yes.
Yes.
So I am Mamoon Rashid. I'll be doing the presentation from Cleveland Clinic, Florida. Our mentor is Dr. Antonio Pinna, and rebuttal part will be done by my colleague, Mohammad Alomari. So first of all, we are dealing with a patient, decompensated HCV cirrhosis. There's a questionable hepatocellular carcinoma, and this patient is not a liver candidate. Why? He had advanced comorbidities. He has intermediate to advanced HCC, or he has advanced age. We should not be offering HCV treatment to him. First, let's talk about the life expectancy. When we do the survival comparison between compensated and decompensated patients, we already know we are dealing with a median survival of 29 months. And when we look at the prognosis of untreated HCC in these patients, with survival significantly decreases with worsening of Barcelona clinic liver cancer stagings. In case of stage B, it's 10 months. In case of stage C, it's 7 months. And in case of stage D, it's only 6 months. So we are already talking about a patient with a questionable HCC, a lifespan of less than 12 months. Now let's look about the effectiveness of hepatitis C treatment in decompensated cirrhotics in the real world. So there's actually not significant change in their clinical outcomes, regardless of their change in MELD score and regardless of their sustained virological response after HCV treatment. So here we are presenting a study from Journal of Hepatology, which is basically a multi-center retrospective cohort study, which was published in 2021. In Netherlands, Germany, and Canada institutes were included. So let's talk about the change in MELD score. After 12 weeks of therapy, there were only 19 patients who actually had a MELD decline of 2 points, whereas 61 patients had a stable MELD. Moreover, when we compare the clinical outcome with change in MELD in child B and C cirrhotic patients, overall clinical event-free survival does not change with change in MELD. Whether the MELD was stable or MELD decreased, their clinical event-free survival was the same. Similarly, their liver transplant-free survival was the same regardless of their MELD score. Now, clinical outcomes according to their sustained virological response. So in patients with decompensated cirrhotics, child with B and C cirrhosis, regardless whether they achieve sustained biological response or they do not, their overall clinical free survival does not change. Similarly, HCC-free survival does not change. And I'm talking about 36 months, and their liver transplant-free survival does not change with the therapy. Let's talk about sustained biological response. Now, in a study in US cohort of veteran patients, we know that SVR is 91% in non-HCC patients, but with a questionable HCC in these patients, we are dealing with an SVR of 74%. And this is regardless of the genotype. This is regardless whether the patient is cirrhotic and regardless whether the patient is treatment naive. Let's talk about the baseline factors which are associated with improvement in decompensated cirrhosis after HCV treatment. These are no encephalopathy, no ascites, albumin more than 3.5, ALT more than 60, BMI less than 25. And we are dealing with the worst patients who probably has all of this, and that's why he's not a liver transplant candidate. So in such patients, the rate of achieving status Child-Pugh A is less, and his rate of death or transplant is high at the end of 36 weeks. And even if we go ahead and treat HCC in these patients, hepatic decompensation is the major driver of death in these patients, as was shown by another journal article, which was a prospective study where the primary endpoint was to study the 5-year. Even HCC was well controlled, the hepatic decompensation, their survival was decreased. And we are already dealing with hepatic decompensation in these patients. And even in treated HCC patients, some of the study shows if you initiate the DEA therapy, there's increased recurrence of HCC in these patients. So we don't have the luxury of that. The predictors of HCC recurrence was DEA therapy initiated less than 1 year after HCC treatment, or non-curative procedure, which this patient has to go for HCC. So there are higher chances of recurrence, which are actually dealing with. Let's go for the current guidelines. ASLD, patients with limited life expectancy within 12 months, they're not going to benefit more from HCV eradication, and therefore palliative measures should be taking precedence in this setting. This is the exact clinical setting which we are dealing with. Let's go to AGA guidelines. Overall decision for DA therapy is dependent on HCC tumor burden, which our patient might have intermediate or advanced cancer. He's not a transplant candidate. Degree of liver dysfunction, he already has decompensated. Overall life expectancy, he already has less than 12 months. So they also, according to guidelines, would not recommend therapy. Let's talk about the clinical trials, SOLAR-1 and SOLAR-2. They also improvement, but unfortunately cannot be applied to our patients because they did not include the patients with questionable HCCs in that. And regarding other guidelines, other clinical trials, most of them, very few patients with increased MELD were included in these studies. So basically, that's why the data is lacking. Now, if we go ahead and do eradication of hepatitis C in these advanced HCC patients, there are some studies out there which might show the overall survival might improve. But again, these are the studies which already excluded the patients who had Child-Pugh more than 9, which we are actually dealing with. Cost of therapy, whatever my colleagues mentioned, just add hepatitis C treatment to that. These patients still will be admitted for decompensated, but in United States and all over with improved sustained biological response, the cost of therapy is increasing, and we are going to add to that. Not to forget about drug-to-drug interactions. These people will be on antidepressants, antipsychotics, some of their cardiovascular medications, immunosuppressants for sure. They will be on antiplatelets, anticoagulants, and there are significant chances of drug interaction. So in today's climate of this decompensated HCV cirrhosis with a questionable HCC, who is not a liver transplant candidate, we are dealing with a patient with low life expectancy. There is no significant clinical impact on clinical outcome, regardless of change in MELD score or SVR. There is emergence of viral resistance if we treat for HCV. There's increased cost of therapy. There are increased chances of drug-to-drug interactions, and moreover, no current guidelines supporting the treatment. Being physicians, I think we have to think globally, not just concentrate on one patient, and we do not recommend HCV treatment in this patient. Thank you.
Thank you so much, Dr. Rashid. Now we are going to hear from our rebuttals. Dr. David Yardeni from the National Institutes of Health will now rebut the Cleveland Clinic, Florida position. I'm looking for a lively rebuttal here.
Hi, can you hear me? All right, if we can,
Yes.
Can you see, are we still sharing screen from the previous presentation or?
It might be nice to take down that slide. That's great. Thank you.
Okay, so all right, so I'm gonna start right now. Okay, so good evening, and I want to thank the American Liver Foundation for giving us the opportunity to present you with our response to the arguments raised by our colleagues from Florida. I actually listened very carefully to the points raised by our competition just right now, and I think and the conclusion from this discussion was that giving the HCV patients under our care with or without HCC the best treatment possible that will keep them well for as long as possible and as long as their lifespan allows, and not complicate their lives with endless admissions and suffering is fantastic. I really do. I also agree that discussing outcomes with patients and explaining them the chances of actually recovering and benefiting from HCV treatment is truly important. However, in real life, it's somewhat more complicated. Before we even discuss the medical aspect of not attempting to treat the HCV patients, as you've just heard, let's discuss the inconvenient topic, which is the financial aspect of it. HCV treatment with DAA is still expensive. That's a fact. However, ongoing inflammation leading to further liver dysfunction, decompensations, and bleeding is potentially several-fold more costly than DAA treatment. And so instead of condemning our patients to further deterioration, we can instead treat them for HCV, and for a substantial fraction of our patients, we can either stabilize their condition or even improve it enough to make their lives better. From a medical perspective, as my colleague Dr. Viana just presented, we have confirmed validated studies starting from 2015 and forward regarding the treatment of decompensated cirrhotics with HCV, showing a reduction or stabilization of the MELD score, improved quality of life, and patients being delisted from liver transplant lists. Because as you've just heard from our colleague, the patients are dying from decompensations. Studies such as the SOLAR studies with letetresfir and sofosbuvir, as well as the ASTRO studies with valpatatresfir and sofosbuvir, have shown it to be possible. In addition, previous studies even before the DAA era have shown us what happens when you don't treat a patient with HCV. What happens is ongoing viremia that significantly increases the risk of liver failure and extrahepatic complications of hepatitis C, such as cryoglobulin-induced vasculitis and lymphoma. One of the difficulties we as hepatologists are dealing with is explaining just how important DAA treatment is for all HCV patients, regardless of the severity of their disease. This difficulty is due to the lack of long-term follow-up studies, as most HCV studies are still younger than a first-grade kid. This is unlike the accumulated data regarding HBV nukes, which have been around for more than a decade, and their ability to improve the patient's condition never ceases to amaze us. I would also like to revisit the Krassenberg and colleagues paper from the Journal of Hepatology published in 2021 that was just presented by my colleague moments ago. Indeed, the study found no benefit in treating child B or C patients due to ongoing liver events in both treated and untreated decompensated patients. However, a more careful look at the paper will show you the definition of a liver event in that study was very broad. For instance, defining liver failure as an increase in the dose of diuretics places a question mark on the validity of this statement. In addition, 40% of decompensated patients included in the analysis on the long-term follow-up were actually transplanted, a finding that further obscures the outcomes of the patient and the statement. I would also like to discuss another study from 2020 by Viana and colleagues regarding the real-world experience from the HCV target cohort published in the Journal of Hepatology. In that study, a majority of the cohort patients experienced hepatic decompensations prior to therapy. However, in the long-term follow-up, 25% of patients achieved an uncanny final MELD score of less than 10. 30% achieved a more than 3-point reduction in their MELD score. Sure, the treatment of decompensated cirrhotics required some painful adjustment. I still remember an HCV patient I took care of in the ICU who was admitted with a diagnosis of acute and chronic liver failure after his family made sure he did not miss a single pill of his medication regimen that unfortunately included an early generation protease inhibitor. But thankfully, newer regimens are much safer. And despite what you've just heard, hepatic decompensation, if you treat a patient, is now a far more rare event. A much more common outcome of treatment is sustained virological response and an improved MELD score, while on the other hand, the common outcome of a compassionate follow-up is dying. So if we have a disease that's curable and curing it can potentially improve our patients' lives, why not use it? Why put our patients at risk for further suffering when we can treat them? As physicians, we take an oath to care for our patients. Sometimes it means to keep calm and help the patient achieve their goal despite the risk of decompensation. So the answer to the question regarding HCV treatment for decompensated cirrhotics is a definite yes. Thank you.
Thank you. Boy, you made it right on the bell. Excellent job. Thanks, Dr. Yardeni. And following Dr. Yardeni, we have Dr. Alomari, who will rebut as well, and from the National Institutes of Health position. So let's hear what you have to say.
You're muted.
You're muted. And maybe could you turn your camera on, Dr. Alomari?
Is my camera on now?
Yes.
Can you see me?
Yep.
Okay. So while our colleagues assume the most optimistic scenario for this patient, I would say the patient is not a transplant candidate for a very good reason. Basically, limited life expectancy due to decompensated cirrhosis and possibly advanced HCC. So just replying to my colleague who just said treatment for HCV improves mortality and decreases decompensation, this is not what we found in the literature. A large multicenter prospective study from Spain by Lindsay et al., published in the Gastroenterology Journal in 2017, revealed that achieving SVR does not typically reverse clinically significant portal hypertension. For example, in those patients with esophageal varices and ascites, SVR did not reduce further liver decompensation or even mortality. Our colleagues mentioned the study by Foster et al., mentioning there was improvement in mid-score, but they did not say that the median improvement was actually 0.85 point at 6 months, which is less than 1. So what does that mean? Two long-term data that was also mentioned by my colleague, real-world studies published in the Journal of Hepatology helped us answer this question. The first one was by Gracia et al. In 2021, and the other by Viana et al. In 2020. With more than 1,500 patients with advanced cirrhosis treated for HCV, they showed even more than 2-point improvement in milk does not translate into clinical improvement. And back to his point that they use a wider definition, their definition was in line with Sharif et al., who pulled the data from all the clinical trials. Yes, it is difficult to define those patients, but they followed the same pattern and the same definition used in the other studies. I'm glad that our colleagues also highlight the data showing improvement in biochemical liver indicators after SVR, but they failed to mention that those studies also reported the improvement may be insufficient to avoid liver-related death or the need for liver transplant in patients with decompensated cirrhosis. Also, these studies, they excluded any patient with HCC, and they were largely limited by short follow-up period, and they only included a few patients with higher MILD, more than 20, which can limit the generalizability to our patient in this 10. Another way to look at it is actually more practical, is to see how many of those treated decompensated cirrhosis patients got delisted due to clinical improvement. And this was answered by a nice study by Bitterman et al., published in the Clinical Gastroenterology and Hepatology Journal in 2020, and said less than 6.1%, assuming all those patients were delisted just because of the DDA therapy. Additionally, as we all know, the DDA therapy response is less in patients with decompensated cirrhosis and HCC. So in a patient like ours, who has limited life expectancy and unclear benefit, why would we increase the failure rate and put the patient at risk having emergence of virus resistance? One last word, as we always strive and try our best to follow the guidelines, both the hepatology and the infectious disease guidelines recommended not to treat patients with hepatitis C virus infection and decompensated cirrhosis if they have short life expectancy defined less than 12 months, as my friend Dr. Rashid mentioned in his presentation nicely. This patient, unfortunately, has limited options, and clearly his life expectancy is limited, and it would be very futile to waste high expense resources that can reach up to $200,000 for the payers in the absence of clear benefit, not to mention the prolonged commitment to daily medications and their associated side effects and drug-drug interaction. This is all assuming we have the luxury of time needed for those medications to achieve SVR and show benefit. As the clinical trials, actually, some patients died before achieving the SVR. So my summary, I think this patient is not a candidate for hepatitis C infection treatment due to lack of evidence and limited life expectancy. And thank you.
Wow, that was great. Thank you, guys. That was excellent pros and cons. I'm not sure we're going to be able to come to a conclusion. You both made great arguments. So it's now time for our question and answers. If our judges can put on their videos, and I think we'll start with you, Dr. Sterling. Questions for the teams.
Yes, thank you all for your excellent presentations in an area that we actually have to deal with quite often. So my question to both sides is there a MELD score beyond which you would not treat, or a ACC tumor burden for which you would not offer the patient anti-hepatitis C therapy?
I can take that, Dr. Sterling. I think 2 or 3 studies mentioned the number MELD score more than 18 to 20. And I think also the Transplant Society, sorry, just maybe the Transplant Society guidelines also mentioned the number 18 to 20 as a cutoff, as those patients unlikely to achieve, like there is less chance to achieve SVR, and they're unlikely to benefit in terms of their portal venous gradient, portal hypertension, and decompensation. So I think that was the number mentioned in those studies that I came across.
We had to agree with the Cleveland Clinic. Around 20 was the MELD score that in some studies were mentioned, but other studies actually mentioned that they're significant compared to retrospective. But some of the studies mentioned that number around 28, more than 21, 18.
And what about the HCC tumor burden?
Can I pick that up? So I just want to add that obviously that's a good question, right? Because literature is still being written as we speak regarding these questions. Essentially, I think that if the patient, as long as the patient is able to sustain the therapy, to take oral therapy, and is not in a stage of his cancer where it's truly in palliative care, I think we should treat. As long as we're not doing harm, I think primum non nocere should be always something that guides us. And as long as we can provide therapy for the patient without causing him further suffering, I think it makes sense to treat, regardless of the burden of the tumor.
I'm just going to add to that. I would just not agree with it. If the patient actually has intermediate to advanced HCC's therapy, it's unlikely going to affect his clinical outcomes regarding if their patient is having active HCC. Obviously, not at this point, he is a candidate for HCV treatment. He needs to be further clarified if we are actually dealing with that type of cancer, and we need to clarify if it's actually HCC. Everything will come after that. But just regardless, just the presence of HCC would not qualify for his treatment.
Thank you, teams. Dr. Janani, questions? You're muted.
I said, great to everyone. This is a, both sides make a great argument. I guess my question to both teams are, if you had someone with hepatitis C, decompensated cirrhosis that you were able to treat with medical therapy, so improve their MELD function, improve their Charles-Pugh-Turcotte score, would you or would you not offer hepatitis C treatment to them?
Well, I will take that. So again, a very great question, and I think it's very related to our topic. Again, it all depends upon the underlying patient condition. So for example, if this patient was a liver transplant candidate, obviously our main aim is after the transplant, we go ahead and we treat these patients, but this is not a transplant candidate. And this, the question comes in what we are dealing with. What is his overall life expectancy? How decompensated the patient is? What is his current MELD score? If this patient had a Child-Pugh score, or his MELD score was around 14, 15, we are dealing with, yes, we can offer that treatment. And in that cases, the researches are good. They show that there is improvement in clinical outcomes. But once this patient crosses the bridge, as my colleague was mentioning, when it goes about to decompensated Child-Pugh B or C, or his MELD increases to more than 18, the clinical outcomes in that scenario is not clear in the presence of active HCC. But otherwise, if this patient was depending on his clinical status, it was compensated cirrhosis, yes, we would have offered treatment at that point.
Thank you.
So can I answer as well?
Yes.
So I just want to say, first of all, first of all, thank you for the question. And then decompensation, as my colleague, Dr. Gracia noted at first, is a wide definition. Okay, when we're talking about decompensations, it could be a patient with Child A who actually has varices or has ascites. It doesn't necessarily have to go all the way to child B and C. And essentially, we're all concerned while we're treating patients that will somehow cause them to fall into the mild purgatory category. But at the end of the day, when we treat patients, we're reducing the rate of decompensation, and we're either stabilizing their condition or improving their mild score. Even if we're stabilizing their conditions and for some reason they get stuck in this mild limbo, it's still probably a good outcome for the patients. And essentially, one has to consider the fact that livers that were not given to these patients will probably go to patients who don't have a therapy, who don't have a cure for their conditions. Patients with PSC, for example. What about the 25-year-old patient with PSC?
Dr. Yardeni, if we could wrap it up, we want to make sure we get to another question.
Sure. Just for a final sentence, if we can treat patients with a cure, with something that we have a cure for, we should do it regardless of the purgatory effect that is possible.
Thank you. And finally, Dr. Ghali, question?
Yeah, so I'd like to ask then both sides a question regarding the if they can put themselves in the other team's shoes and think how they might affect decompensation, either improving or worsening. So for the pro team, is there a subset where treatment might actually make their decompensation medically worse? And I'm not talking about protease inhibitors, without a protease inhibitor. And for the con team, is there a subset of patients where you think the treatment actually is beneficial and perhaps the reason for not treating is something that's soft like age?
Thank you. And if you could keep your answers brief, please.
I'll take it for the cons team. I think if this patient was to be a transplant candidate and has a life expectancy more than 3 months, I would treat this patient. And also, I'll be short and leave the remainder of the answer to the other team.
So I think that the patients that should not be treated, it's the ones that are in the ICU currently dealing with active decompensations or patients with short life expectancy. But as our team mentioned, and HCC, it's a great example for Ed with advanced liver disease, but really how many patients are not transplant candidate because of malignancy? It's less than 20% in some Canadian cohorts, because I couldn't find actually US data. So really we're talking about this broad decomp patients, but the ones I would not treat probably are those patients that have low life expectancy, as the ASLD guidelines mention them, probably less than 3 months.
Well, thank you. I'd really like to thank all of the debaters. You did an outstanding job. I think it was very robust and you made very, very good points, both of you. So thank you to all of our debaters. So now we're ready to move on to debate number 2. The clinical question here for this debate is whether or not TIPS should be placed in patients with HRS-AKI. And as a reminder, pro presentation 8 minutes, con 8 minutes, and then our rebutters each 5 minutes to refute the opposing team's presentation. So for our pro, we have Yale University, and on the con side, the University of Maryland Medical Center. So I'll now introduce the debate teams for this second debate. Presenting the pro position that TIPS should be placed in patients with HRS-AKI is Yale University. Dr. Guadalupe Garcia-Sao will be our mentor here, and mentoring Dr. Anahita Rabi and Dr. Saad Safo. The next team, the con position, this will be the University of Maryland Medical Center. Our mentor here is Dr. Sasan Sakiani, and our debaters will be Hannah Blaney and Dr. Mian Khalid. So Dr. Rabi from Yale will now present their pro position.
Hi, everyone. First, I wanted to thank the American Liver Foundation for giving us this opportunity. I also wanted to thank our mentor, Dr. Garcia-Sao. I'm going to start sharing my screen. Okay. So today I'm going to show you why we should be using TIPS for patients with HRS-AKI. Just a little brief background on the definition of HRS. So this is a functional renal dysfunction in the absence of any structural renal disease. So HRS-AKI has replaced the old definition, which was HRS type 1. And this is the one that we'll be focusing mainly today. In terms of the pathophysiology of HRS, it all starts with cirrhosis leading to increased portal hypertension. In turn, this results into splanchnic vasodilation. With the sequestration of the blood in the splanchnic circulation, the effective arterial volume decreases. This will result in compensatory mechanisms, neurohormonal activation, most importantly, renin-angiotensin-aldosterone and the sympathetic nervous system activation. This will result in sodium and water retention and leads to refractory ascites, and also results in renal vasoconstriction, decreased in GFR, and subsequently HRS. The current treatments that we have act on the counteract the splanchnic vasodilation, and their goal is to mainly increase the effective arterial volume and also counteract the neurohormonal activation. However, the problem with these treatments is as soon as you withdraw these treatments, a good proportion of patients will have recurrence of HRS as the portal hypertension, the main driver, is not addressed. Liver transplant remains the finite treatment. However, this is not available to many patients due to organ availability problems, and also not everyone is a candidate for transplant. TIPS acts upstream in the pathophysiology of HRS, and that is why TIPS works perfectly for this situation. So TIPS decreases the portal pressure by creating a shunt between the portal and the systemic circulation. By offloading the sinusoids, the portal pressure decreases, and the blood that was previously sequestered in the splanchnic system will be shunted towards the systemic circulation, and that will improve the effective circulatory volume. In the next few slides, I'm going to show you studies that looked at the effects of TIPS on the hemodynamics in patients with HRS type 1. The number of patients in these studies are small. However, these included very detailed hemodynamic assessments. So this is a study from Spain that looked at TIPS placement in 7 patients with HRS type 1. The portal pressure gradient was decreased from 21 to 13, and this resulted in downtrend in the plasma renin activity, aldosterone, and norepinephrine at 7 days, and then again at 30 days, which resulted in improvement in kidney function, improvement in GFR, and also urine volume. This is another study looking at 5 patients with HRS type 1 who were responders to midodrine and octreotide. The portal pressure gradient was decreased from 16 to 8 after TIPS placement. The plasma renin activity, aldosterone, norepinephrine all decreased over follow-up. The patients were followed for 12 months, and they were all alive at the end of follow-up. GFR, renal blood flow improved, and the urinary sodium excretion also improved over follow-up. This is another study looking at 31 patients with HRS. These were patients who were not transplant candidate. The study is from Germany. The portal pressure gradient after placement of TIPS decreased from 21 to 13. Creatinine clearance and sodium excretion improved in the group that received TIPS. However, in the group that did not receive TIPS, the renal function deteriorated. And the second slide here, you can also see the mortality. As you can see, the group that received TIPS, they had much better survival compared to the group who did not receive TIPS. This is a meta-analysis looking at patients with, the first graph is the patients with HRS type 1 and 2. And this is looking at renal function improvement in these patients. 83% had improvement in renal function after TIPS placement. And this number was 93% in patients with HRS type 1. Looking at the literature and systematic reviews on efficacy of, for example, terlipressin as medical treatment, the effectiveness is about 52%. So 52% of patients will have reversal of HRS. And the other problem with that is about half of these patients will have recurrence as soon as the terlipressin treatment is withdrawn. And the same meta-analysis also looked at survival rates. Short-term survival in these patients was about 72%, and one-year survival in these patients was 47%. And looking at the literature in terms of survival with medical treatment, it's being reported to be between 35 to 41%. So my opponents might bring up that these are really sick patients and they're not going to do well with TIPS placement. So this is the data looking at patients with ACLF, mainly in the setting of variceal bleeding. And the patients who received TIPS actually had much better survival. And this is propensity matched based on baseline factors and severity of liver disease. And looking at the Table 1 and demographics of these patients, as you can see, these patients had MELD of 19. That was the mean MELD. And also about 80 to 86% of these patients were child C patients. So these are really the sickest of the sick patients, and they still perform better when selected appropriately and got TIPS. Obviously, the patients need to meet criteria for TIPS. Contraindication to TIPS include congestive heart failure, untreated valvular disease, moderate to severe portal hypertension, hepatic encephalopathy, which is refractory, and a tumor in the liver parenchyma that might not allow us to place TIPS. So in conclusion, TIPS in select patients with HRS-AKI can play a key role in reversing the pathophysiology of HRS and lead to improvement in renal function and survival.
Thank you very much, Dr. Rabi. Excellent overview. And now we will go to the con position, Dr. Khalid from the University of Maryland. Make sure you unmute yourself.
Yes, I just wanted to make sure. Okay, perfect. Okay. Good evening, everyone. My name is Mian Khalid. I'm one of the GI fellows at the University of Maryland, and we'll be presenting on TIPS we placed in patients with HRS-AKI. The con side, my mentor is Dr. Sasan Sakiani, and my partner is Dr. Hannah Blaney. So our key points are there is a paucity of high quality research studies, which is the reason why we do not think that TIPS should be placed for patients with HRS-AKI. These patients are often extremely sick with a really high mortality rate. A lot of the studies that our counterparts at Yale University brought up, there are significant patient selection issues and critical patient selection issues that we will definitely bring up. In addition to that, TIPS is known to increase risk of hepatic encephalopathy, cardiac decompensation, and hepatic insufficiency. Despite patient selection and really careful patient selection, these adverse effects and downstream effects from TIPS cannot be ignored. Also, knowing that these patients are really sick to begin with, liver transplant should be a priority for these patients because of high mortality. And we also have terlipressin as a viable alternative, and we'll talk about that very soon. So our first point is we are actually lacking high quality studies. If you've noticed, a lot of the studies that were brought up earlier are almost 20 years old. And even the more recent studies are small subset of patient population. Almost all of these studies are not controlled in very limited clinical scenarios. HRS-AKI has a high mortality, about 90% and average survival time in 2 to 4 weeks. Liver transplant is a known effective treatment. That being said, we don't have transplant availability for every patient, which is why we need to figure out alternatives. And that's why TIPS was brought up as a bridge to transplant for these patients. There are some prospective studies and some retrospective studies. However, small patient population, 7 and 16 patients. And also a lot of the retrospective studies were mixed. If you notice earlier, HRS-1 and HRS-2, known as HRS-AKI and HRS-AKI. These studies were mixed, which is not the topic of question today. We're focusing solely on HRS-AKI, and these are really the very sick patients. And currently, TIPS is considered experimental by almost all the major liver society guidelines. This is a table from Song et al. In 2018, and really nicely brings up the different studies that have looked at TIPS in HRS-AKI. And as you can see, in a very small patient population, the maximum was like 41 patients, at least in this table. And also, there are strict exclusion criteria, bilirubin cutoffs for patients, not significantly elevated bilirubin. In addition to patients with GI bleeding were excluded as well, and that is important as well. And I would also like to bring up how HRS-1 and 2 are mixed in a lot of these studies. Patient selection is critical. We would definitely want to bring up the gender disparity. A lot of the studies actually include 65% males, 60 to 65% males, and excluding the fact that only 30-35% of women are often included. And there is a mortality difference between men and women in these studies. The largest observational cohort study, about 80,000 patients with 1.2% receiving TIPS, was a Sherlock et al. Study. And it showed that there is a mortality benefit of TIPS only that was evident in men, despite the fact that female gender was a significant predictor of inpatient mortality in the TIPS group. Different studies have also noticed gender disparity as well, which is troublesome. More recently, the Trivedi study in 2019 noted women have a 6-fold higher odds of death compared to men after TIPS creation. No one really knows why that is, but it doesn't help that a lot of studies are excluding women in the patient population. Not knowingly, I think it's just the patient population that's presented, but that includes selection bias. This is a table from the Trivedi et al. Study that actually shows really nicely how the unadjusted mortality rate between men and women. So in men, the black is actually medical management and gray is TIPS. So in men, there is a significant improvement in mortality, but in women, not so much. And there's a thought process that there's lower GFR for a given creatinine compared to women for women. And I'm sorry, women have a lower GFR for a given creatinine compared to men. So there's an underestimation of liver disease severity in women, which introduces systemic bias. And there is an inclusion of sicker female patients. So if you're only including 30 to 35% of female patients, then you might be changing the outcomes, unfortunately. Another important patient selection difference is variceal bleeding. So that was excluded in the Sherlock study, and it's also excluded in a lot of other studies as well. So our concern is this actually underestimates really sick patients with portal hypertension. Understandably so, the idea is that you only want to focus on HRS-AKI patients. However, in the hospital, we see patients in all colors and backgrounds, and patients with HRS-AKI are sick patients who will often have variceal bleeding as well. And in a different study in Anderson et al., they actually showed that when you included TIPS for variceal bleeding, there was no statistical improvement in renal function. The third point we want to bring up is TIPS complications. There is definitely an increase in hepatic encephalopathy that all of us are well aware, about 30 to 40% in different studies. Another important point is the bilirubin cutoff. A lot of studies exclude patients with a high bilirubin. A pre-TIPS bilirubin more than 3 is actually a powerful independent predictor of 30-day mortality for patients who are getting TIPS. So that's why this is excluded for a lot of patients. So there's a 40% increase in risk for every 1 increase above 3.0 milligram per deciliter. There is a risk of cardiac overloads. If a patient gets tips for HRS-AKI and they happen to develop pulmonary hypertension or cardiac abnormalities later on, that would actually jeopardize their liver transplant listing, which is the only way HRS-AKI is treatable currently. There is, again, a high mortality for HRS-AKI. Various society guidelines going from Italian to German to EASL to ASLD actually view it as investigatory currently, and data is insufficient. This table really nicely summarizes it. Hepatorenal syndrome, which is one of the indication for TIPS or presumed indication for TIPS right now. Insufficient data across the board. Elevated creatinine actually has a negative predictive value for survival after TIPS. We all know this from the Malin shot study from 2000. This is a seminal study where they actually viewed the creatinine, bilirubin, and INR, and that's how we have the MEL score. Even if there is short-term improvement in renal parameters for HRS-AKI if patients receive TIPS, this will improve renal parameters short-term, decreasing MEL score for some patients. But overall, at the end of the day, if these patients are going to be lower down on the transplant list, that will jeopardize their liver transplant position as well, especially since TIPS is not a permanent solution. We do think terlipressin is a viable alternative. The most recent confirmed trial with almost 300 patients, a randomized double-blind placebo-controlled trial. And unfortunately, terlipressin is not available in the US, but there was an HRS reversal that was significant shown in this study. This cannot be sent for TIPS because there is not a single randomized controlled trial for TIPS when terlipressin is something that we should be focusing more of our energies to, or actually looking at larger scale randomized controlled trials for TIPS to figure out whether this will be helpful for HRS-AKI. In conclusion,
this is the timekeeper. Time has expired.
I'm sorry that we had to cut you off, but it is now time for Dr. Saffo from Yale to rebut the University of Maryland position. Dr. Saffo, if you can turn on your camera, please.
All right. Good evening, everyone. I'd just like to thank the American Liver Foundation and our colleagues from the University of Maryland for the opportunity to discuss this topic with everyone tonight. So first, I'll just start by reiterating probably the most important take-home point that we talked about, and that's there's a strong physiologic basis for using TIPS for HRS-AKI. HRS is on the very same clinical spectrum of complications that occur due to portal hypertension. That includes ascites, refractory ascites. We've shown that TIPS attenuates the neurohumoral mechanisms that lead to HRS, and this is evident by the fact that the concentration of key markers like renin, aldosterone, and norepinephrine often decrease after shunt placement. Furthermore, although early clinical studies are small, they do suggest a benefit when it comes to hard clinical outcomes like survival, and we feel like they support larger scale RCTs. Our colleagues from Maryland focused a good portion of their discussion on the complications of TIPS. This is obviously a central issue that comes up with any discussion relating to TIPS. But medical and technical advancements in the last 2 decades have led to improving efficacy and safety. First, we have a plethora of data regarding appropriate patient selection, some of which they mentioned. We now have PTFE-coded shunts, and increasing expertise amongst both hepatologists and IR providers would have led to significantly lower rates of stent dysfunction and need for reintervention, which have been shown in more than one study. We've begun employing small caliber shunts as small as 6 millimeters, which reduces the risk of hepatic encephalopathy by about 50%. And we started using rifaximin 2 weeks prior to shunt placement and subsequently thereafter, which reduces the risk of encephalopathy by more than 1/3. Along with that, we are proposing that we have very strict patient selection. The patients who are getting TIPS for HRS are not having this done on an emergent basis as they would for bleeding varices, and therefore they should have a complete cardiac workup prior to the placement of the shunt. So patient selection is clearly something we should keep in mind very closely. Someone is an immediate transplant candidate, we agree that that patient should probably proceed to transplant, but If not, this is clearly an important therapy that can be offered. We agree that there are gender disparities in the application of TIPS, and there's a paper that they mentioned along those lines, but that exists for many medical therapies. But to my knowledge, no RCTs have shown that TIPS is less effective for women. Patients with terlipressin, patients who receive terlipressin and other medical therapies, only 50% of them have reversal of their HRS. And so that leaves another 50% that we can potentially treat. And the patients who do have reversal, there is a high risk for recurrence of HRS as the pathophysiology still exists. And so as the study that Anahita showed, those are patients we could potentially target with TIPS as well. So I realize that data is currently limited, but over the coming decade, I do expect that clear evidence will emerge supporting the use of TIPS for HRS. In the meantime, as providers who are caring for patients who are perpetually considered to be high risk for almost any intervention, I think that we can all agree that it's incredibly frustrating to tell patients that the theoretical risk of complications of a procedure outweighs the very real risk of death in the absence of intervention for a disease that our colleagues mentioned carries a median survival of, and that's measured in weeks essentially. TIPS is a calculated intervention. It's not an open thoracic or abdominal surgery. It's a catheter-based IR procedure with a very acceptable safety profile that can be life-saving. For now, I strongly believe that we should apply this modality in a carefully selected manner for patients with HRS-AKI. I think the question that I force myself to answer when facing any challenging decision, and one that I would ask you to consider, is that would you want this done for a close family member or friend if they had HRS today? And in that case, I would opt to give my family member or friend the best possible shot with TIPS. So I just wanted to thank everyone again.
Thank you very much, Dr. Savo. And then for our last speaker in this debate, Dr. Blaney from the University of Maryland will now rebut Yale's position.
So thank you so much for the great conversation this evening. It was a very interesting topic that has been very enjoyable to learn about and discuss. So TIPS, as it's well known, given that TIPS is known to worsen hepatic function, performing TIPS in this population with HRS-AKI is very high risk and can lead to decompensation. And there's been several studies that have shown that in many cases you'll have increased MELD scores in certain populations. I believe it was the Anderson et al. Study that demonstrated increased TIPS scores after placement of TIPS for HRS, despite having improvement in the creatinine. As my colleague, Dr. Khalid, mentioned, these studies that have been done, they have very small patient populations, several of them with populations less than 10, and there are no randomized controlled trials among these studies. There was a lot of consecutive studies, retrospective studies, but really no randomized controlled trials that are investigated these. Also, one thing with these studies that were done is these patients were not, yes, they were sick, but they were not as sick as many of the patients that we at least see in a tertiary care center. In the Anderson 2010 paper, their MELD, average MELD was 15.2, and several of the other studies up to 18, which are within the realm of where IR is comfortable performing a TIPS procedure. In comparison, a lot of the other studies on terlipressin, the MELD, average MELD score is above 30. And so as my colleague also discussed, we really need to define the patient population where TIPS may be beneficial. The gender disparities are quite pronounced. Women already have a worse waiting list mortality in the time of the MELD score was described by Moylan et al. In 2008. The Trivedi study in 2019 was a large database study and quite remarkably showed a 6-fold higher mortality of odds of death after getting a TIPS for HRS compared to men. Again, the selection for having a sicker female population, given most likely the low muscle mass and lower creatinine in female patients. And similar findings were also found in a large database study by Charlot in 2020, and so replicated. There were also a few studies earlier that showed, including Wong et al., suggesting that in 2004 that TIPS may be beneficial following treatment with octreotide, midodrine, and albumin. And this study, again, only included 5 patients receiving TIPS. And so while it was overall promising.
I think you have frozen.
Okay.
Dr. Blamey.
Have I unfrozen?
You know what? You're good for the rest of us. So keep going.
Okay. And this study only included 5 patients, but again demonstrates that TIPS and HRS-AKI is really understudied. Again, while the prospect of TIPS and HRS very promising, it's not recommended in the 2018 EASL guidelines or the 2010 AASLD guidelines, both citing insufficient evidence. And we do have evidence-based options, as Yale mentioned. Our medical options aren't great, but they are well studied. And we really need to see large randomized control trials with comparison to things like terlipressin or octreotide, midodrine, and albumin before we can recommend TIPS HRS. And again, really trying to find and define the population where this is beneficial to do as minimal harm and most benefit as we can for our patients.
Thank you to both teams. Those were excellent arguments. And now we'll turn to our judges to start asking some questions of our debaters. Our first question from Dr. Denani.
Thank you both teams for such great arguments for the pro and the cons. So my question to both teams is, with the new definition of HRS, is there a MELD cutoff or criteria that could be applied to better select patients that should undergo TIPS?
So I can start. I think MELD is kind of a tough parameter to choose just because it does include the creatinine itself. And so I don't know if I would say, there should be a strict MELD cutoff. There are studies which have shown that various components of the MELD, including the total bilirubin and the INR and the sodium, have sort of prognostic value after TIPS placement. But essentially, a lot of the studies that have looked at preemptive TIPS or TIPS in ACLF patients have had patients with very high MELD scores, and they've been safely done. So a consideration could be for having a total bilirubin or INR cutoff in patients who are getting it strictly for HRS. And a lot of the studies, that was somewhere, total bilirubin cutoff somewhere in the ballpark of 5, although it ranged. And in the preemptive TIP studies actually went all the way up to 40. So that can be a consideration, but for a clinical trial purpose, but it's likely safe even in some patients who have very high synthetic values. So.
I actually agree with Dr. Sappho. TIPS MELD is actually problematic in many ways, especially recently. There's this new thought process that maybe MELD 3.0, including like female gender and albumin, is something that better captures, how sick patients are. And after MELD 3.0, the most recent studies actually showed like women actually gained like a lot of points on the transplant list. as well. So not only for tips, like any interventions that we do right now, I think having like a MELD cutoff would be problematic. So I think it's definitely something should be studied a bit more in a randomized controlled trial setting, which is something we were bringing up earlier to better elucidate what a patient selection would be and biochemical markers would be that can predict how patients will do after tips or not.
Thank you for those answers. Dr. Ghali, do you have questions for the debaters?
Yes, so I'd like to ask both teams if the change in definition of HRS in any way affects your opinion one way or the other, and if not, why not?
I can take for the Yale team. So I think the previous definition of HRS, especially HRS type 1, would actually start treating these patients much later. So when the creatinine was above 2.5. However, with the new definition, someone with a creatinine of 0.5 going to 0.8 or 0.9 is going to be marked as having AKI. So the whole cascade of treatment and getting to the diagnosis of HRS is going to be happening much faster and much earlier. So this actually, if the studies that I presented were mostly in HRS type 1, with the new definition, I would assume TIPS is going to actually be performing better and it's going to be more beneficial because we're going to be starting it much earlier rather than waiting until the creatinine is all the way up to 2.5, which is going to be really not reflecting the severity in someone who has already muscle wasting, and creatinine going from 0.4 to 1 is a big change for these patients. So I think that with a new definition, we'll be catching them earlier and TIPS is probably going to function better.
I'm just going to make a comment that none of the studies that we went over that are available used the current definition, the updated definition of HRS-AKI, which makes it a lot harder to tease through really what the data means.
Thank you. And Dr. Sterling, do you have a question for our debaters?
Yes, I think it was the Maryland team had brought up the concept of maybe sequential therapy with giving 48 hours or 72 hours of medical therapy, and then maybe thinking a TIPS might be, good in that group. So for the pro group who want to go right to TIPS, would you consider a short course or 48 hours of therapy in the terlipressin trials? If you're going to get better, you're going to get better pretty quickly. And if you're not, you're not. So would you consider deferring treatment or deferring the TIPS with a short course of medical therapy to see who might get better? And for the con group, would you consider considering TIPS if they failed medical therapy for 48 or 72 hours?
So who wants to go first? Maybe the pro team?
Sure. Yeah, so I do agree. I don't think in most cases there's a substantial harm to giving a short trial of medical therapy. I will highlight that although we sort of think as medical therapy as being less invasive than TIPS, we do have to consider the fact that medical therapy involves going to the ICU, having a central line placed, and receiving medications that do themselves carry a risk of complications. So norepinephrine and vasopressin being two medications that we'd commonly use in the United States, risk of arrhythmias and risk of ischemia. Now we use fixed dose vasopressin, but prior to that, patients often received titratable vasopressin, which notoriously caused gut ischemia. So these aren't necessarily harmless interventions to be viewed as something that's lesser of two evils going down that route first. But I do agree, generally speaking, I think you do have to think about patient selection. There may be patients who you would think maybe should go down the medical treatment path first, but there are patients who frankly may need TIPS for other reasons as well. And it may not make as much sense to wait, send them to the ICU and have them go down that route. I do think there's probably TIPS can probably be applied in both cases. So
just one quick thing to add to that. the recurrence rate with medical treatment is pretty high. As soon as you withdraw the treatment, a good proportion of those patients will have recurrent HRS.
And our con team, you get the last say.
I think we do think, we all know HRS-AKI has an extremely high mortality, like 90% over 2 to 3 weeks. That's why these patients are the sickest patients in the hospital. And we want to do everything we can to make sure that we give them best outcome as possible. After 2 to 3 days of medical treatment. That's why, a lot of the studies, 20 years ago, and also more recently, have been looking at TIPS as a way to figure out whether there is something that can be a bridge to transplant. Our thought process is TIPS may be useful in a very carefully selected patient population with some encouraging results in these small studies. But the issues are, patient selection is such an important thing, as Dr. Safa mentioned earlier as well. TIPS can have multiple indications, but if we're excluding patients with variceal bleeding and want to perform TIPS on patients only for HRS-AKI in a very small number of patient population, we're not really getting the full picture. I think this is something that needs to be studied, a crossover medical treatment followed by TIPS in a patient that's more holistic, variceal bleeding, HRS-AKI, getting a better sense of short-term outcomes, especially since these patients are so sick, to see if there's an alternative to transplant, since so many patients are dying on the transplant list, and giving them some hope. So I do think this is a knowledge gap that needs to be studied, which is why we're having this debate tonight and spirited debate tonight to figure out what's the best thing we can do for these patients.
Thank you very much. So another great debate. You guys did a wonderful job. I really appreciate all of the arguments and all the hard work that you put into this. So our next debate, our third debate, we will now introduce. Now, the key clinical question here is whether or not endoscopic variceal surveillance and primary prophylaxis of esophageal variceal hemorrhage is indicated in cirrhotic children. So again, the same timekeeping as before, as outlined here. And now we will welcome each of our rebutters separately after our pro and con. So here on the pro side for this question, we have Boston Children's Hospital, and on the con side, Brown University. So here we have our pro position mentored by Dr. Elisaphan, and debating on the pro side is Dr. Nastasio and Dr. Mills. On the con side, we have Dr. Casper, who is our mentor, and the fellows representing Brown University, Dr. Christine Andrews, as well as Dr. Rahia Raymond. So if we're going to start, we will start with the pro position from Boston Children's. Dr. Camilla Mills, you will be our first speaker. Dr. Mills, I can see your slides if you want to unmute.
Okay. Good evening. My name is Camilla Mills. I'd like to thank the American Liver Foundation for allowing us to participate in this event this evening. I'd also like to thank our mentor, Dr. Scott Elisaphan. So tonight we'll be presenting the pro for our portion of the debate, and our topic in particular stance is that endoscopic variceal surveillance and primary prophylaxis of esophageal variceal hemorrhage is indicated in cirrhotic children. So I'd like to begin by reviewing what we know and why it matters. We know that cirrhotic patients are at risk of developing portal hypertension, and portal hypertension has been found in 2/3 of long-term biliary atresia survivors specifically. We also know that variceal bleeding is a well-established as well as a dreaded complication of portal hypertension, with bleeding occurring in approximately 30% of patients with varices. Varices endoscopically are found in greater than 50% of patients with cirrhosis. And this number has been shown to increase to 70% for children with biliary atresia specifically. Furthermore, cirrhotic patients have a significant risk for developing high-risk varices. So high-risk varices are defined as those that are grade 3 esophageal varices, grade 2 esophageal varices with red well markings and or gastric varices along the cardia, or gastric varices with or without esophageal varices. In this particular large study of 1,300 children with portal hypertension who underwent upper endoscopy, they were found to have high-risk varices present in 32% of cirrhotic patients. And this particular figure highlights this, and the patients were divided into 3 separate categories. And I've highlighted in the red boxes the number of patients with high-risk varices from each group. So the first group is those that did not bleed without primary prophylaxis. The second, those that bled spontaneously, followed by those that underwent primary prophylaxis. And again, the overall take home here is that high-risk varices were present in 32% of children. So now let's discuss the risks associated with variceal bleeding. From a mortality standpoint, we also know that cirrhotic patients have a high mortality risk. And here we highlight a large retrospective cohort study using the Pediatric Health Information Systems data from 50 tertiary care children's hospitals in the United States. And the goal was examining mortality and risk factors associated with esophageal variceal bleeding in children. In this particular table from that study, we see that mortality during any bleeding encounter was noted to be just above 7%, with that number reaching to almost 9% at 6 weeks post-bleed. There's also a significant incidence of morbidity associated with acute variceal bleeding in children. This particular figure comes from a retrospective cohort analysis of 57 children with acute variceal bleeding who were admitted to the Hospital for Sick Children in Toronto during the years of 2000 and 2015. And they found that post-acute variceal bleeding was present in 64% of first-time bleeding episodes. And what you can see in this table, the most significant morbidities noted were ascites, infections, respiratory complications, as well as ICU admissions. Next, looking at the benefits of endoscopic primary prophylaxis, this important study of endoscopic primary prophylaxis in 110 children who underwent endoscopic banding or sclerotherapy. As you can see in this table, it shows that around 70% of children had eradication of varices. This same important study highlights that endoscopic primary prophylaxis was also associated with decreased morbidity and mortality, as well as a reduction in future bleeding. And the figure on the right displays 10-year overall survival, which was noted to be 93% for children with cirrhosis. Furthermore, endoscopic primary prophylaxis has been shown to be associated with low complication risk, fewer potential procedures and hospitalizations, less anesthesia encounters, which makes care more cost-effective for patients and healthcare systems as well. So to summarize our key points, high-risk varices are present in greater than 30% of cirrhotic pediatric patients, and cirrhotic children with varices have been shown to have significant morbidity and mortality. And endoscopic primary prophylaxis is associated with variceal eradication, improved overall survival, decreased bleeding, future bleeding episodes, fewer hospitalizations, and low complication risk. And so for all of these reasons, we believe that endoscopic variceal surveillance and primary prophylaxis of esophageal variceal hemorrhage is indicated in cirrhotic children. Thank you.
Thank you, Dr. Mills. And now Dr. Christine Andrews from Brown University will present the con position.
Good evening, and I'd like to thank the American Liver Foundation for having me here tonight. I will be arguing the counter view, which is that endoscopic variceal surveillance and primary prophylaxis of esophageal variceal hemorrhage is not indicated in children with cirrhosis. And I'd like to just start by reminding us all of the core tenet of our field, which I think is really how we should be looking at this problem. First, do no harm. And why I bring this up is to say that to be doing something such as primary prophylaxis, we're talking about doing a procedure on people who have not yet had an event. In this case, we need to clearly meet a burden of proof that shows that we are not doing harm and there is a potential benefit. And to think about that framework, it's really important to consider about other things that have to surmount this level of proof, such as making a clinical practice guideline. And in essence, that's what we're arguing here. We're talking about if primary prophylaxis should be indicated in children with cirrhosis. We're essentially promulgating this as a new guideline. So I think it's good to frame it in this way with similar goals to a guideline, where one, our goal is to overall improve outcomes where our benefits must clearly outweigh our harms. And two, it's to standardize care based on evidence-based practices. So with that framework, I'd now like to discuss why I do not think that we're at a place where primary prophylaxis of esophageal varices in cirrhotic patients meets these two standards. When we evaluate the overall risks and benefits, I think it's fair to say that we would not even be considering surveillance endoscopy unless we're potentially going to be intervening. And these potential interventions include endoscopic variceal ligation, sclerotherapy, and non-selective beta blockers. And while most studies are limited and we do not have any randomized control studies adequately assessing the utility of primary prophylaxis in children, most of these studies are retrospective cohort studies that focus on the most commonly used forms of primary prophylaxis, which has been really endoscopic variceal ligation, plus or minus the use of sclerotherapy and non-selective beta blockers. And I'd like to bring your attention to one such study. This is a study published by Chen et al. From 2021, where they look at 58 pediatric patients, 38 of which went into the primary prophylaxis group, 20 went into the secondary prophylaxis, and observe them over a median 13-year retrospective follow-up period, including over 1,000 upper endoscopies and 346 endoscopic variceal ligations. And what they show is potentially maybe at 5 years, there might be a difference in 5-year esophageal variceal bleed with 14 versus 32%. It did not meet statistical significance, but more importantly, if you look 10 years out, there was actually a similar 10-year esophageal variceal bleeding risk overall. More importantly, they found no significant difference in long-term mortalities between primary and secondary prophylaxis groups. This was not without complications. So of those 58 patients, 6 patients had complications, so just 10%. 3 had esophageal stenosis, 2 had esophageal ulcers, and 1 had post-banding immediate bleeding. Moreover, they showed a very high esophageal variceal eradication failure and recurrence of esophageal varices. So this was both in the primary and secondary prophylaxis group, they showed that they were able to eradicate 55% after a median of 3 banding sessions. But of these, 53% of them had recurrence of esophageal varices. So ultimately taken together, there were really only 26% that had a durable esophageal varices eradication. So all of this is to say that performing banding can result in significant complications, and it was really of uncertain durable benefit. These data also were reflected in the data presented by Matthew Duché in the most recent virtual Bovino pediatric research workshop this past October. He discussed his experience in primary prophylaxis of varices in children among a center, and he did show, like my colleagues in Boston had mentioned, there is a high rate of eradication, and they showed that with sclerotherapy and banding. They showed that time to eradication was 6 months over 2.8 sessions. However, again, there was a very high recurrence rate. There was actually 43% recurrence, some of which occurred only 2 months out. Furthermore, the worse the varices in terms of the scoring, the higher risk of recurrence. And this is your Kaplan-Meier curve just showing the degree of recurrence rates that we saw. So the long-term benefit of primary prophylaxis is very unclear. And so this begs the question, are we just spinning our wheels here? So by doing primary prophylaxis, are we just doing a lot of procedures that are eradicating our varices in the short run without a change in our long-term outcomes? And are we potentially causing more unintended harm by doing this? Apart from not having enough data to support the benefits of primary prophylaxis, there's overall a lack of standardized protocols in place right now. In fact, there's no validated or standardized scoring system for grading of varices in children. There's also data in the literature out there that shows that there's a lot of inter-observer variability between one endoscopist and another endoscopist of how we even grade these varices. There's a lot of procedural variation as part of this, including just the learning curve to perform these procedures, and even just general endoscopic technique differences between one provider and another. As an example, how many bands do you place per session might differ between one endoscopist and another. And then also there's concerns with pediatric safety, efficacy, and dosing. And this is particularly true with non-selective beta blockers in children. There's a lot of data really questioning the safety of this, and we don't even know what is an effective dose in children. So this segues really well into probably the most important argument. So while there's clearly insufficient data in the pediatric world, some may argue that we should be considering primary prophylaxis in children based upon data from the adult literature that show a potential benefit. However, I would argue that in this particular scenario, it would be very inappropriate to do so. And the reason behind this is really ultimately because of the underlying causes of portal hypertension and cirrhosis are different between children and adults. In adults, it's hepatitis C and alcohol-related cirrhosis, which of course leads to their own set of comorbidities. In children, we're talking about biliary atresia and extrahepatic portal vein obstruction as the most common causes, which tend to be more compensated forms of cirrhosis. And just as an example to demonstrate the fundamental differences, there was a study 2 years ago by Ebel et al. That showed that hepatic venous pressure gradients did not correlate with the degree of fibrosis, the degree of varices, or history of variceal bleeding in children. However, in adults, this is used regularly to predict patients at risk for portal hypertension. So the pathophys here is clearly very different between adults and children. Moreover, kids, as we know, have very unique physiology, and the use of beta blockers can potentially be very harmful. In particular, just in the same way that you use different pressors in children, this is no different. So by giving beta blockers, we're potentially blocking their tachycardic response to increase their cardiac output. So starting them on this drug can potentially be fatal. So in summary, going back to our initial framework, where we demonstrate a clear burden of proof to uphold a guideline, I hope I've demonstrated that there's insufficient data to show that primary prophylaxis would definitively improve outcomes, nor that it would result in standardization of care based on evidence-based practices. Therefore, at this point, until we're able to gather more robust data, I think it's fair to say that we simply do not have enough data to say that primary prophylaxis should be performed in children with cirrhosis.
Thank you, Dr. Andrews. I'd just like to say, as an adult hepatologist, I'm really glad I never have to answer this question. So to rebut Brown University's position, we have Dr. Nastasio from Boston's Children.
Good evening, everybody. I also want to thank the American Liver Foundation for the opportunity to discuss this topic. I think that for many years, it was thought that in children with cirrhosis and portal hypertension, the mortality of first variceal bleed was extremely low. And in fact, our colleagues from Brown did not even mention what is the mortality from first variceal bleed. The truth, however, is that over the past 15 years, there have been multiple reports indicating the variceal bleeding as the concrete risk of being a dramatic event with significant mortality and life-threatening complications. As shown by my colleague, you saw that the recent study by Molleston, which included almost 700 children with cirrhosis, showed a mortality of variceal bleeding of 8%. And in 2017, Duché reported that 1 out of 5 patients with cirrhosis, so 20% of patients with cirrhosis and variceal bleed, had a life-threatening event defined as an event resulting in the death of the child before liver transplantation, or as events requiring emergent liver transplantation. So I just wanted us to keep in mind these two numbers: 8% mortality, 20% life-threatening complications. But of course, we can not only worry about mortality, and as my colleagues show, morbidity is also present in 60% of patients after a first bleeding, with the infection being the leading cause, followed by new onset ascites, signaling a decompensation of cirrhosis. So I think the results from all these studies show us that the high-risk endoscopic pattern, which is described in adults, also applies in children. And I 100% agree with our colleagues that from Brown that although children are definitely not small adults, But we cannot forget that in adults with medium to large varices on screening endoscopy, primary prophylaxis is the standard of care and has been so for 20 years. And that in adults, primary prophylaxis is actually considered a life-saving treatment, which also decreases morbidity. So I think that with all these available data, it's really impossible to not consider preemptive treatment of varices at high risk of bleeding as a fundamental aspect of the management of children with cirrhosis. And we also agree with our colleagues from Brown about the controversies in beta blockage, and that this is why we support endoscopic primary prophylaxis. And indeed, we think that endoscopic primary prophylaxis has shown to be effective, as my colleague showed, in eradicating varices in 70% of pediatric patients. And even as our colleague from Brown showed, the more recent data presented by Duché at the Bavino conference just a few months ago showed an eradication rate of 93%. And moreover, not only endoscopic primary prophylaxis is successful at eradicating varices, but it is also striking that the 10-year probability of overall survival for children with cirrhosis and high-risk varices who underwent primary prophylaxis is 93%, compared to 76% of those who bled spontaneously, which was shown by Duché in his study from Journal of Hepatology in 2017. And of course, I want to discuss safety of this procedure. And as our colleagues from Brown, we are very careful in addressing this issue. And the safety of prophylactic endoscopy has even recently been shown in a study on 87 children just out of University of Missouri, Kansas City. Only one patient treated with band ligation developed a partial esophageal stricture, which required a one-time balloon dilation without need for any further management. The remaining complication across 339 endoscopic procedure was only 2%, and all of these complications were managed with supportive care only. And in terms of safety, I think it's important to point out too, that in these studies, patients who underwent primary prophylaxis had a lower median number of endoscopy throughout the treatment course compared to patients requiring secondary prophylaxis. So they required less anesthesia and less procedures overall. So in conclusion, while I agree that a prospective randomized control studies with long-term outcome would be ideal to establish some guidelines, we have to come to terms with the fact that not only these studies are not always feasible in the pediatric population, but also that we do not have the luxury to wait years for these studies to results before making medical decisions. And more importantly, we've shown you tonight how we already have extensive data proving that variceal bleeding in children with cirrhosis is indeed associated with significant mortality, 8%, life-threatening complications, 20%. And we already have a preemptive treatment, which is endoscopic prophylaxis, which has been used for over 20 years in adults, and that we now know that is also safe and effective in children as well to prevent variceal bleeding. Thank you.
Thank you, Dr. Nastasio. And finally, we have Dr. Raymond from Brown, who will now rebut Boston Children's position.
Good evening, everyone. Thank you to American Liver Foundation for giving me an opportunity to talk today. I would like to start my rebuttal by emphasizing that primary prophylaxis of esophageal variceal hemorrhage is not indicated in cirrhotic children. My colleagues from Boston did discuss the benefits of doing primary prophylaxis of variceal bleeding in children, but honestly, the data that we have is limited. The landmark studies discussing the benefits of primary prophylaxis were not free of adverse outcomes or risks either. And I would like to point out that the study by Duché et al. That was mentioned by my colleagues at Boston, in that study, out of 110 patients which underwent banding or sclerotherapy, adverse outcomes were noted in a fair number of patients, including a total of 21 bleeding episodes during endoscopic treatment. Early bleeding occurred in 17, which is about 15% of total patient population, and relapse of high-risk varices in 31, which is around 28%. And ultimately, 68 patients, which is about 61%, ended up needing liver transplant. In the prophylaxis group, 8 patients died, which is 7%, versus 12 patients, 8.5% in the no prophylaxis group. So even with early intervention, if you look closely in the study did have adverse effects, including bleeding risk. My team partner also discussed some of the other studies with similar outcomes in her presentation. I would also like to point out that in another study by Helsinki, in which prophylactic endoscopic sclerotherapy was done in kids with biliary atresia and repeated 2 to 4 weeks interval, Recurrent bleeding after sclerotherapy occurred in about 44% of patients, and esophageal varices occurred in 60%. Even though the prophylaxis group had lower mean number of endoscopies, as mentioned by my colleagues at Boston, I would like to mention two recent studies here. In one retrospective study published this year by Slowick et al. In Nature Scientific Reports, no deaths related to variceal bleeding were found in that study, and there was no difference in immediate or late complication in the two groups. In a study also by Lee et al., which was published in 2021, there was no statistical difference found in eventual outcome that was alive with native liver between the two groups, primary versus secondary. So I would just like to say here that it just seems that we don't have consistent, strong data yet. In order to establish evidence-based guidelines, we need prospective control, multi-center studies. So for the positive findings my colleagues have mentioned, including improved survival rate, mainly come from studies from one center. Whether that data is applicable to children elsewhere is yet to be seen. We need further studies to compare safety and efficacy of primary prophylaxis to watchful waiting. Even though the prospective studies may be challenging in kids, but there is currently a large multinational registry for pediatric portal hypertension, which recently started, and that can help us in answering our questions in future. But I would conclude my argument by saying that based upon current data and available studies, we should not subject children to unnecessary procedures and interventions unless we have consistent, favorable data demonstrating clear-cut benefits to support our arguments. Thank you.
Thank you very much, Dr. Raymond. So now we'll move to our questions. Dr. Ghali, I think you have the first question for our debaters.
Yes, first I'd like to thank all the teams. This was really remarkable. So with the caveat that I am an adult hepatologist, my understanding is that there is a disproportionately high number of bleeds from varices in the youngest children, especially those with biliary atresia. So my question to both teams is, if you were going to do pharmacologic or endoscopic treatment for the presence of varices, what is the best way to assess the efficacy of that treatment? And what are the risks that are specific to children over and above those in adults?
Somebody from the pro team want to start?
Sorry, I was having some technical difficulties. You said, can you repeat the question?
Especially in the youngest children, those with biliary atresia who are very young, what's the best way to assess the efficacy of pharmacologic therapy and the efficacy of endoscopic therapy, considering that the varices are a little bit different in children, and what are the risks specific to children?
Yeah, I think that for pharmacologic therapy, we really do not have enough data, and with I agree with our colleagues from Brown. In children, like the few studies that we have, they usually target a reduction of the heart rate by 20 to 25% for beta blockers. But the reality, the reason why we're worried of doing that in children is that children rely on heart rate, on frequency, much more than on stroke volume. And this is something very different from adults. So the issue and the fear is that by giving a beta blocker, children will not be able to compensate appropriately in a situation of like hemorrhagic shock or any type of shock. So I really don't think that we have enough data to support beta blockers, especially at such a young age. Does my colleague want to take the other part about the scoping, Dr. Mills?
Yeah, definitely. I'll
Sure.
take
So, sorry. Just to add what my colleague said, in terms of endoscopic prophylaxis and therapy, from that standpoint, I think we do have, as I showed in my presentation, some data from some centers that have used these therapies, sclerotherapy and banding, to help control varices, primary and secondary prophylaxis wise. And so far, I think the data shows from these studies that, this is a safe and effective method for pediatric patients. And I think going forward that, we just need to get the collective experience from more centers so that we have more data to inform this particular area.
Thank you. And from our con team?
Yeah, I can go first. So I definitely agree with use of beta blockers and the argument presented by my colleagues at Boston, because we don't have enough data to use beta blockers in kids, especially if they have different response to shock and hemodynamics. In terms of like using sclerotherapy or banning procedures, we have to be careful, like in small kids. It's really hard to do banning depending upon their size. And a lot of times we end up doing sclerotherapy. And as I mentioned in some of the studies I cited, sclerotherapy, even after you do like primary prophylaxis, there is a huge risk of variceal recurrence as well as recurrence of bleeding. So there are just like some challenges in doing these procedures in kids. So I would just like to say that.
And just to add to that, to what my colleague just mentioned, it's really the size with kids. It's less than 10 kilos. You can't do banding because it can't actually fit through the device. So that's why sclerotherapy is used in the younger than 10 kilo kids. But I think like this is exactly highlighting the issue is we don't have efficacy data on, even the use of beta blockers. How are we going to see efficacy? We don't know that at all. So there's a lot of risks that have yet to be really borne out in the literature. And I think the International Multi-Center Pediatric Portal Hypertension Registry that my colleague mentioned is really necessary to just give us more data basically to inform what we're going to do.
Thank you. Dr. Sterling?
Yeah, one of the groups mentioned a little bit about the recent Baveno conference. And so have the Baveno criteria, particularly as it relates to platelets and perhaps liver stiffness measurement, which can easily be done in kids. Can that help identify sort of that super high risk patient who might really benefit through this difficult procedure? Or and I just looked at the recent Baveno criteria and I don't remember that being mentioned.
Yeah, not to my knowledge, like we are not there yet as in adults to have like a specific cutoff for liver stiffness that would like point us in a direction or the other. There is, we do use liver stiffness routinely in our patient, and we are starting to use the spleen stiffness as well, but we do not have criteria that will guide us for the management of varices.
Thank you.
I think that I would
right
add
ahead.
In terms of us, in terms of the need for just further data before we really give a guideline to support the use of prophylaxis in kids.
Great, thank you. Dr. Janani?
I guess my question is around the utility of non-invasive markers, specifically things like FibroScan or even some literature, like for instance, on the pill cam in risk stratification of patients who are at risk of varices. Either group. What are your thoughts on that?
I will say that in our center, we definitely use FibroScans quite often to evaluate patients. And I think that that's a very good non-invasive way for us to look for signs of cirrhosis and to help inform us about if a patient has portal hypertension, and helping us, further stratify their risk for having varices. And that can help us to categorize a patient as someone who is likely to have high-risk varices and then more likely to benefit from endoscopic surveillance and primary endoscopic prophylaxis as well.
And in terms of the pill cam, yes, we use it. Of course, it's for older children who are gonna be able to, swallow it. So we do have these limitation, but yes, we do use it.
Excellent. Well, again, thank you to all of the debaters and to the mentors. This was a great conversation. I learned a lot from this debate. And now we will take the opportunity to give our judges some time to deliberate on all three debates. I think we need the next slide here. Before we conclude this debate, I would like to express our gratitude again to our generous sponsors for the support of the academic debates tonight, our national premier supporter sponsors, AbbVie and ASI. So I would also like to extend our deepest gratitude to everyone who has been involved with the academic debates. As a gentle reminder, there is still time to donate. Nothing is too small and nothing is too large, so that the American Liver Foundation can continue to do its important work. You can find the link to make your donation in the Q&A box. I think it should be there now if you'd like to donate. And while you are making your donation and we begin making closing comments, all of our mentors and debaters will join us for the final comments of the evening. I would like to, I think everyone is supposed to turn on their cameras now. Great job, teams. I would like to congratulate. I've done this before with our fellows. I've moderated before, and I will tell you, this is a huge amount of work. I just congratulate all of the debaters. It's very clear that you put a lot of effort into this. Your arguments were crisp, they were clean, they were very well articulated. The mentors did an outstanding job. I think these are difficult questions that we had tonight. And I think all of the teams did an outstanding job. But I would also like to thank our judges. Great questions from our judges tonight, the ALF tech team, and of course, I would like to thank all of you for joining us this evening. As a reminder, the Debate Madness will continue each night this week. Please register for these important virtual programs. There will be different debates every night, and so and different teams every night. So please register for these and help promote them to the healthcare community. Please remember also to visit the ALF website and recommend it to your friends, family, colleagues, and patients. As a reminder, the ALF has many resources for patients and caregivers. We offer exceptional educational programs to our healthcare professionals, and we encourage you to visit the links on this slide to explore all that we have to offer. And please encourage your patients to visit us too. Please visit our social media and like us on Facebook and follow us on Twitter and Instagram. And I would do that if I understood how to use Twitter. The Liver Walk is a signature event of the American Liver Foundation. It allows people affected by liver disease to come together to raise awareness and funds. It also gives them the opportunity to support each other in a festive and inspiring environment. We are happy to announce in 2022, we are planning to host 13 in-person walks across the country. You can see them all listed here, as well as a virtual walk. Visit liverlifewalk.org for more information and ways to participate in your area. The Liver Life Challenge is the American Liver Foundation's official endurance program, where dedicated athletes across the country use their passion and commitment to go the extra mile for the liver community. You can ride or run with us in 2022. Visit liverlifechallenge.org to take on the challenge. You can see they're listed here: bike tours, marathons, and I'm not sure what El Tour de Tucson is, whether it's a bike or running, but I'm sure it will be exciting. The Legacy Galas recognize individuals who have made an outstanding contribution to the liver community, the fields of biotechnology, medical innovation, and philanthropy. Both galas will host families, medical professionals, organizational partners, and business visionaries in the healthcare, pharmaceutical, and biotech industries. And to learn more about our galas occurring this May and October, please visit alfgala.org. The American Liver Foundation advocacy represents more than 100 million Americans affected by liver disease. Together with volunteers and coalition partners, we advocate on behalf of our liver patients, their caregivers, and all those impacted by liver disease for increased federal research funding, public health education, and improved patient treatments and coverage. And to learn more or to become an ALF advocate, you can visit liverfoundation.org/advocacy. The American Liver Foundation has built a private Facebook support group community of biliary atresia family members and patients, moderated by an ALF staff member and a biliary atresia parent and patient that will launch on April 6th. The community will provide a peer network, reliable information to biliary atresia families, and will have exclusive monthly educational programs from pediatric liver disease experts on different topics relating to the BA journey. This will also give the members an opportunity to ask experts general BA related questions. You can share this with your patients to be part of the community and access the monthly forums, Life with Biliary Atresia, an American Liver Foundation Facebook support group. ALF will bring together up to 50 rare liver disease stakeholders, patients, caregivers, hepatologists, primary care providers, patient advocacy organization personnel, and industry representative for a 4-hour virtual roundtable to identify solutions for improving the health outcomes of our patients with rare liver diseases. This meeting will focus on answering the following questions. How can people avoid misdiagnosis and achieve earlier diagnosis and earlier connection to care? How can we educate more people about genetic testing and best address concerns about stigmatization? And how can we reduce the patient burden and improve the overall patient experience? This is set for June 22nd and 23rd. And to receive an invitation for our first Rare Disease Summit, please email Ivory Allison at iallison@liverfoundation.org. So I'm now looking for the winners here. And has somebody given me the winners?
Yeah, I think I can do that.
Okay.
You were on some of these emails, these texts. So are you ready for you want me to announce them or do you want to?
Yep, go right ahead.
Okay, so the first, I have to look up, it's dark here in my room. So the first debate, looking at patients treated with decompensated cirrhosis or HCC. The winner of that debate was Cleveland Clinic Foundation.
Great.
The second
Congratulations. We need to do congratulations to everybody.
Debate number 2, which was should tips be placed in patients with HRS-AKI? This is a very difficult one for us. It was not a complete consensus, and this one was based more on presentation with the data that they had, and the winner of debate 2 went to Yale University. And the third debate, looking at endoscopic surveillance and primary prophylaxis in children, went to Brown University.
I just want to say again, there are never any winners or losers in these debates. These are hard questions, ones that we grapple with as attending physicians all the time. I always learn so much from all the fellows. They've done so much research with the help of their mentors that really outline the critical questions and the tough decisions I think that we face as physicians every day. So really great job to all the teams. Thank you so much for all the hard work that you put into this. Whether you won or lost, everyone gets a star tonight, okay? Or maybe many stars. So we thank you again for joining us tonight at our first Academic Debates Madness Week. We hope you've enjoyed participating in and attending the event as much as we did. Tomorrow, both the participants and the attendees will receive an email from us with a brief survey. This is the first time I think this has been done. So we're posting the link. Here it is on the Zoom chat if you'd like to complete it now. And I think, we'd appreciate your feedback so we can make next year's debates even better. So there's still 3 more debates to go. So we hope you will join us tomorrow night for night 3 of the Academic Debates Madness. Thank you and have a really good evening.